Oh, yeah. All right, thank you guys all for coming and your patience as we set up. So we have 4 experts here for you guys to talk to, and we'll do one at a time just for the microphone situation. But first up is Dr. Jenko, and if you want to just say your name and title,
Sure.
so they all can capture that.
Okay.
You'll probably have to spell it as well. And then if you can just go into kind of why we're here and what you've been seeing, but if you need to have any prompts, just we'll jump in for that too.
Okay, sounds good. So my name is Mike Jenko. I am the Chief Medical Officer at OBC Hospital. And so in my role as Chief Medical Officer, I'm really responsible for overall quality, safety in the hospital. I serve as kind of a liaison between the medical staff and the hospital, help coordinate care between those two groups. And really, we're here today, I think, to talk about what the region is experiencing from a COVID standpoint, but also from a healthcare capacity standpoint. And luckily, I've got 3 excellent partners here who are, like me, living it every day, and I think can provide some insight and some understanding that maybe will help folks in our community kind of get a handle on what's going on and where we're at and what those folks are experiencing when they come to the hospital to get health care.
Well, can you spell your name first?
Sure, it's Genco.
Okay. Yeah. So what are you seeing at OBC Hospital?
So at OBC Hospital, so in our location, we have a fairly large catchment area. We have been operating at or above capacity for quite some time now. We are seeing a significant amount of patients who have COVID that are requiring inpatient hospitalization. But in addition to that, we're also seeing folks with non-COVID conditions that are requiring hospitalization, higher numbers than probably what we had seen pre-COVID. In my opinion, that's probably due to a couple of different reasons. I think that over the last year and a half, a lot of folks with chronic medical conditions have been facing a lot of barriers and having a lot of trouble managing those chronic medical conditions. And unfortunately, when that happens, you tend to get flare-ups of things like diabetes and congestive heart failure and COPD, and oftentimes those things have to be treated in the hospital. So we really are seeing 2 populations that have both increased at the same time. We're seeing greater need from our traditional inpatient population, but we're also seeing a greater need from our COVID population.
Well, we've spoken to many people who have been waiting several hours when it comes to trying to get ER care. Are we still seeing increased wait time trends?
Yeah, absolutely. And again, I think that all stems from the fact that there are more people trying to use a fixed resource. And unfortunately, when that happens, folks wait. That's the unfortunate truth of it.
So one of the things in talking to someone who entered Virginia Beach General a couple weeks ago is and was turned away because of a low-grade fever and it didn't meet what would be a standard COVID requirement. What are the requirements to be admitted into the ER? I mean, I understand things are on a case-by-case basis, but COVID specific, is there a plethora of things that you're looking for that people meet so they can go ahead and get treated right away and maybe not turned away to monitor their symptoms?
Sure. Yeah, that's a hard question to ask, to be honest, because like you said, it really can vary on a case-by-case basis. And so, when a patient comes into the emergency department and the physicians and providers there are making a decision, what's the best place for this person to continue to receive care, there's lots of factors that go into that. Certainly the patient's current symptoms, their other medical problems, what kind of support do they have at home versus what kind of support's available in the hospital. You have to take all those things into consideration. And I can't speak to any one case, obviously, without more details on it. But there are a lot of things that go into consideration in addition to what are the patient's symptoms.
What about the trend of patients that you're seeing now? Are you seeing the majority of the people coming into Sentara hospitals that are unvaccinated?
We're seeing the majority of people that are coming into the hospital being admitted for COVID, yes, are unvaccinated, between 80 and 90%, depending on which facility you're talking about.
What's your message for people who are fearing getting vaccinated?
So we have seen, so I would say, obviously, there's a lot of data out on the vaccine. We've had a lot of experience, certainly within our own staff, on folks getting the vaccine. It is a safe vaccine, and it works. The thing about the COVID vaccination is it will help prevent you from getting COVID, but more than that, because there will be some people who still get vaccinated and get COVID, more than that, it prevents you from getting really, really, really sick from COVID. And so, if you're vaccinated and you get the Delta variant, you'll feel bad, but a lot of that can be managed at home. The patients that get really sick, that require critical care, that are intubated, the vast majority of those are unvaccinated. So in our own hospital at OBC, we have seen a number of unvaccinated folks who, as they're getting intubated, when they come off of the vent, are begging to get the vaccine because of how bad that illness has and how intensely it affected them. And so my message to folks at home would be, if you're on the fence, don't wait until you get it to decide you want to get the vaccine. Don't wait until one of your family members or loved one has gotten it and you've seen what they've gone through. Get the vaccine before. You can avoid a lot of that if you get the vaccine.
How often do you treat people for a negative reaction to a vaccination or any kind of contraindication to a vaccination?
I don't have the exact numbers on like adverse reactions from vaccines. Among our own staff, it has been exceedingly rare. I probably can count on one hand the number of times that we've had to send someone to the emergency department or have had to observe anyone or watch them. We haven't had to admit anybody for a vaccine reaction that I'm aware of. So again, exceedingly rare.
We know that 18 months ago, the numbers of the patients that you were treating with COVID were in a senior citizen elderly range. What are the trends looking like now? I remember a couple weeks ago when we were at Sentara Lead, it's looking like the numbers are more in that 30 to 50 age range, people that are incredibly healthy, no pre-existing conditions. What are the trends looking like in terms of age now?
No, I think you summed it up well. We've definitely, so you're right. In April of 2020, we saw a lot of folks who were in that elderly senior citizen population who were getting sick from this. It has now moved to the younger population. The 30 to 50, I think, is spot on. Among people that are in the hospital, we do see certain comorbidities associated with admission. Diabetic population is particularly at risk. Obese population is at risk. Folks with underlying lung disease are at risk. Certainly folks who are immunocompromised are at risk. So that's the population that we're seeing end up in the hospital. And you're exactly right. We're seeing a lot of younger people in the ICU ventilated because of this disease.
What kind of differences are you seeing with treating people now in terms of, especially with the Delta variant, in terms of the symptomology and things that are people coming in versus previously?
I want to make sure I understand the question. So are we treating them any differently?
No, I mean just in terms of the symptoms that people are experiencing, via the Delta variant versus previous variants.
Sure. Certainly a lot of the same symptoms from before. I don't think that we have seen quite as much in the loss of sense of smell or taste with Delta as we have with some of the other ones. But again, a lot of folks, the really, really sick folks are coming in with the respiratory symptoms. Those are the big things.
Can you describe sort of the obviously, if you're at capacity or above capacity and someone comes in, low-grade fever, whatever, and they get turned away, that's an impact. But for the folks who are admitted, what is the downstream impact for them or for the staff to have a capacity operating or a hospital operating at or above capacity?
It takes longer to get them in the right place. So ultimately in the hospital, you want to get the right patient to the right place at the right time. And when you're at capacity, that happens slower.
Okay, we'll have someone else speak now.
Sorry.
We don't want to save all the questions for Dr. Sentara because we've got other people. So did you want to switch seats or switch mics?
No, switch seats.
Switch seats.
Okay, is that okay for your background and all the things? Okay.
Yeah.
Steve, you want to go?
Sure.
And these are respiratory therapists at Virginia Beach General Hospital. And do you want to start by saying and spelling your name? I know that'll be something that I want to hear.
Sure, my name is B. Barajas Williams. It's BEA, and then Barajas is BARAJAS-Williams.
Job title in hospital.
I am the manager of respiratory therapy at Virginia Beach General.
What have you seen in Virginia Beach General?
We're seeing a lot of COVID patients that are really, really sick and that are requiring a high level of care from respiratory, from nursing resources as well. Yeah.
When you're treating these patients, can you give us an indication when they get COVID, how long is it taking on average to get some normalcy back in terms of, lung capacity and breathing? We've heard anywhere from months to a year. Give us sort of an idea of what COVID does and how long it takes to be kind of fully recovered and back to somewhat normal.
So I think I can speak more to what's happening in the hospital. You start off with a patient obviously going into the emergency room and they get assigned to, say, for example, a med-surg floor. Prior to COVID, if someone was requiring med-surg care, that's someone who's not requiring oxygen or maybe 2 liters of oxygen. Now you've got someone who's requiring 60% oxygen to 100% on the same floor. That requires a lot of resources. So then, they may either get bumped up to intermediate care or just go straight to the ICU depending on capacity and get intubated there and ventilated. You're talking about probably, a month to 2 months in the hospital dealing with this illness. And then after that, depending on what the outcome is, if that person goes to a rehab facility, I'm not sure what happens there. I'm sorry.
So some of your sickest patients, you're saying, are in the hospital from anywhere from 30 to 60 days?
That's right. Yeah. Because it requires so much care for them. They're on a ventilator, they're on high oxygen demands, and then of course the trajectory of that with other, I don't want to speak to other things, but just everything else seems to come with it, the skin breakdown, the deconditioning of the body and things like that from being intubated for a long time. Yeah.
Can you kind of, because I know we kind of see a lot of it on TV, maybe 1 or 2 nurses probably talk to, national networks about what they're seeing. How are nurses doing going throughout this pandemic? What are their emotions, what are their thoughts as they're caring for these sick and sometimes dying individuals?
It's very difficult because, again, when we receive these patients, we get to know them, we work with them, we talk to them, we develop a relationship with these patients, and then we follow them throughout the trajectory of their illness, and that's really heartbreaking because now it's not just somebody that's coming into the emergency room in a trauma acute situation where you don't know them, you intubate them, now you're intubating someone that that you've probably said hi to their family member on FaceTime, and it's really heartbreaking. And just, we obviously all have these conversations with each other and we lean on each other and we try to be that support system for each other.
How much worse on the respiratory system has the Delta variant been compared to the original mutation of the virus?
I think that it's just the more striking thing for me is just how young they are. They're 40 years old, they're 30 years old, and these people are our age. It used to be where they were 60, they were 70, 80 years old, where you have some perspective of, okay, you're sick, but now they're so much younger, and these individuals, they're worried about their families, they're worried about the bills that they have to pay, their life outside of the hospital, and just the long haul of that,
Younger demographic, you would think they would be a little bit more resistant, generally in better shape
Yes.
than seniors, et cetera.
Yes.
But the Delta variant is overcoming even those factors, is that what you're saying?
Absolutely, and it's also just something that I find just really sad is that, they require such 100% oxygen, they can no longer get up and go and use the restroom or brush their teeth. They have to get somebody in there to help them to use a bedside commode, You know, that's something that someone who is 40 years old is just not used to doing. You know. Good.
Lucy, do you want to go next? Or, please?
Thank you, guys.
Hi, I'm Lucy, and I'm the clinical nurse manager of the General Intensive Care Unit at Norfolk General Hospital, this hospital. I would say my daily, day-to-day duties, first and foremost, I am a nurse. I'm frontline with my team every single day. Even though I'm their manager and I manage the unit, we are all one big team, and I'm a nurse with them on the front lines. What questions do you have for me?
What do you see in here?
So, I'll try not to get emotional, but we see a lot of very sick patients, and they're very short of breath, and they're very scared. A lot of them say that they wish that they had gotten the vaccine. I look around in my unit and across the hospital, and I can only speak for what I see. And I see that at least 90% of these people are not vaccinated. And so what that tells me is that the vaccine works. Our patients, they can come into the ICU on high flow oxygen, and they've progressed as they have come in through the ED and gone to med-surg and gone to step down, and we're their last resort. We have difficult conversations every day. The team members, the nurses, the physicians, you know, conversations, do you want us to do chest compressions on you? Do you want us to put you on the ventilator? Do you want to continue to struggle to breathe? Or are you wanting to give up the fight and be made comfortable? These are decisions that they have to make every day and conversations that we have to have every single day. And it's really difficult, and I can't even explain it, how difficult it is.
How do you guys deal with your mental health and your other fellows' mental health when you're constantly dealing with this every day?
I think that's a really good question. I have an amazing team of nurses. I think everyone who's ever been to my ICU would agree. We lean on each other. I have wonderful leadership and educators and everybody that we lean on. And we make sure to check on each other. We make sure to keep our morale up. We do things for our unit that are kind of unique. And we have to do that. We have to continue to have little baby showers and things like that, and to have some type of normalcy through this COVID crisis, because that's what's going to get us through it.
What has attrition been like? You have people quit. Are you feel a lot of openings right now, or are people kind of been able to weather the storm?
So personally, I can only speak for my unit. I know there are many, many openings through Sentara, I think 815 or something like that openings. I'm fortunate to have not had a lot of movement. I have a very unique group of nurses and care partners that really have been together for a very, very long time, and so I have not had a lot of turnover at all. But I do have 3 positions open. Yeah.
Stay away from our nurses.
Okay.
I know we talked a lot about some hospitals being short-staffed. I imagine it's not much of the same case for you, but I know sometimes there are some nurses that might contract COVID, which has to take them out. So have you been seeing some of that, which puts you, at that short staff capacity?
So I wouldn't say that we're not short-staffed. I would say that our staffing struggles really come from patient acuity and how sick our patients are. So I'm just going to say last year and a half, we were seeing the older population of patients and things like that who were sick. I mean, we're a level 1 trauma center. We are used to very, very sick patients, but COVID takes it to a whole entire different level. So this second, strain of COVID is younger patient population. They are so much sicker, and I can say that we have been treating a lot of pregnant patients, more than we've ever treated in probably the history of our unit
With COVID.
with COVID.
When you look around in your office looking, there's got to be a breaking point of how many beds you can have, how many people you can actually keep up with. Are we getting close to this point?
So I'm not sure. We have not turned people away from care. I can say that. I can say that the wait times are longer down in the ED, potentially waiting to come up to the ICU, but that you are going to get the care that you need if you come to the hospital. We don't want to discourage people from coming to the hospital.
What is the status of elective surgeries, I should say, and is there consideration to halt them or cut them back?
Honestly, I live in GICU.
Yeah, I don't think she
Okay.
Yeah, sorry, I'm not the right person for that question. Sorry.
Also, mine, all of Sentara, it's not,
Yeah.
and we haven't stopped all elective surgeries or anything, but some are being postponed on a case-by-case basis, depending on the hospital and the day. But that's a decision that they're making on a
Yeah, that really is a day-by-day.
Yeah, I'm not.
It's not like a
You're better
all
to answer that than I am.
Those postponements to go them to the COVID surge.
I think the combination of everything you're hearing, yeah.
So we are just sort of coming out of summer, heading to fall. Is there concern? Have you guys talked about what's coming down the road? Do you have any idea, what that's going to look like, given that you're nearing capacity or in some places at capacity now?
I would definitely say that we're concerned. I would say we have lots of plans in the works, and we'll take care of whatever comes our way.
Lucy, do you have anything, one last final message, I guess, to the community members who might be watching this?
I would like to tell you guys that we are exhausted. Nursing staff, respiratory therapists, everyone that I've spoken to, I work with the critical care team and residents, we are exhausted. But we also really love what we do. And we want to continue to fight for, Hampton Roads and all of your loved ones. But I want to urge you to speak to your doctors and get vaccinated. That's it.
One other thing, did you give us your last name? I think we've been calling her Lucy. Did you?
I'm fine with Lucy. No, I'm just kidding. And my last name's Vincent.
Vincent, well, you just touched on something. I mean, you guys took an oath to do this, much like somebody signing up for law enforcement, and you're talking about how exhausted you are, yet you're treating unvaccinated patients that haven't trusted science. How is that a mental toll for you guys too, in terms of you took this on, but these people didn't, follow guidelines?
That's a good question. I would say that we wouldn't not want to treat an alcoholic who came in for, complications of being an alcoholic or a drug user and things like that. Not that you can kind of say that in the same toll with a vaccination, but we did take an oath. We do have a responsibility to our community to care for them, and we're going to continue to do so.
All right, we have one more person for the question chat. Did you spell your last name for everyone? V-I-N?
V-I-N.
V-I-N?
Yes,
Name, spell it for us, and which hospital you're in?
All right, I'm Clarissa Sanchez, C-L-A-R-E-S-A, last name Sanchez, S-A-N-C-H-E-Z. I'm patient care supervisor at Sentara, Virginia Beach General. I'm sort of the jack of all trades nurse on duty. I deal with helping with admissions, getting people into the beds. Staffing is a big thing that I do. Support for the nursing staff, the medical staff, rounding, making sure everybody's got what they need to go into their shifts.
So what's it like over there at the hospital?
We're at capacity. We're busy. We're seeing numbers that we haven't seen in a really long time. Our ER waits are 4 or 5 hours. We're admitting patients, a lot more admitted patients, and like Lucy had said, they're staying longer. So we're having people wait in the ED a lot longer to get these beds, to get people discharged and out. So, like Lucy said, we're tired. Nurses are tired. The ED has been getting crushed. They're tired, and they are trying to do the absolute best that they can. We've got patients in every little nook and cranny that you can think of. trying to do the best that they can to take care of them.
I don't know if this would fall under your purview, so let me know if it doesn't. But, you know, it would seem that in these unfortunate cases when someone has to be admitted for COVID, that is also a good intervention point to talk to family members about the need to get vaccinated. And I'm wondering, logistically, is there a way to actually bring vaccines to other people who maybe are at a point where they're like, okay, yes, I want to get the shot?
I know that we have clinics throughout the area, Walgreens, Rite Aid. Sentara has a number of clinics that offer the shots, the vaccines. So it's just a matter of getting them the resources that they need,
But
or
not
just
at
the
that
information,
point.
not
So
in the hospital
we do
generally.
have an inpatient vaccine program, so all inpatients who are not being hospitalized for COVID can get the vaccine here, you know, at their bedside, and their family members can as well. So I'm assuming, if I can double check with our pharmacy lead on this, if it's being offered to other patients as appropriate, if a family member has that conversation with the care teams, they can also get vaccinated if they want to. Anyone can get it.
I was not aware that Sentara offered that. That's
Yeah,
awesome.
yeah.
That's great. Good information.
Send you a flyer.
How much do you like, you know, when you reach those really, really peak times where, you know, you're at capacity, how much do you leverage other resources at other Sentara hospitals, even other hospitals in the region? You know, if you have, you know, a COVID patient or another patient who needs that immediate care, that you can't just, you know, have them, you know, either wait the ER for, you know, that lengthy period of time or things like that.
So if people are really, really sick and they require intubation, they need to go to the ICU, we make it happen. Yes, they're at capacity, they're very busy, but we, you know, will downgrade patients, we'll assess patients, see who can move out of the ICU to bring somebody into the ICU. Worst case scenario, the patient is held in the ICU for a bit until they can get a bed. But we do everything that we can to get the truly sick people up first. I hope that answers your question.
I'll ask you the same question. How are the nurses handling it over there? And how are we doing for the nurses for their mental health and getting through?
Well, I give a lot of hugs, a lot of encouragement, a lot of elbows. You got this. This is what we trained for. Get in there. They're tired and they're stressed out emotionally and physically. As nurses, I was an ER nurse for 17 years. I mean, this is what we do. We want to give the absolute best care that we can. And they are being halted with the number of patients that they have, kind of just what I call like trauma nursing. You're getting in there, you're getting the meds, what do you need, and out, and then to the next person. They're not being able to have those conversations, spend some time with the patient, spend some time with the family, because they're really trying to take care of all the very sick patients they have. A lot of them are med-surg nurses that don't really do the traumas or the critical care people. They're seeing a lot more codes on the floors that they're not used to, so it's a little time-consuming for them to run in there, do a code, try to regroup afterward, and then move about their day. They're very stressed out and they're very tired.
When you say at capacity, I can speak for myself. I don't know scale-wise what that means. At Virginia Beach, what does that mean at capacity?
I'm not sure on the numbers, but capacity means more patients than beds. Every hospital is different in the amount of patients that they can take. I think roughly Virginia is around 460 beds maybe. That's including, you know, cath holding, things like that. But
So Virginia Beach General is around 460?
I could be wrong. I don't have the exact numbers.
I don't know.
I'm not a number person.
We're talking hundreds of people filling every available space basically in the hospital.
Minus, you know, PACU and cath holding, you know, those beds that we could always use to overflow patients. The problem comes with enough staff to take care of those patients.
PACU is post-anesthesia care unit. What was the other term?
Cath holding. The cath
That's
lab.
the catheterization.
Yes, sir.
Cath holding for heart catheterization?
Yes.
Yeah.
Right. We also can share a document that actually has the number of hospital beds for all 12 Sentara hospitals.
Yeah.
Thank you.
I think Beach is like 250 or something.
258.
258. Beach is 258 licensed.
Ah.
But is it, I'm sorry to interject, but when you're saying at capacity, is that, obviously
I can only speak to my hospital and what I've seen. When we are at capacity and every ICU bed is filled, we look very hard at the patients to see who we can downgrade, who we can move to a lower level of care. Now, sometimes those patients may not be ready, but we're asking our step-down nurses to do more ICU care. We're putting the least sick people in a lower, I won't say a lower level of care, but to another area. They're still going to get that care. They're still going to see the physicians, but we're taking care of the sickest people that we can. But we make it happen, one way or another. We do make it happen. ICU, they're amazing.
I mean, maybe you guys can answer this, but is it safe to say that all of the ICUs at Sentara hospitals are at capacity?
I mean, we're near or at about.
I would say it
It's-
varies from day to day.
Yeah.
True.
But it is a day to
Near
day.
or at capacity?
It varies from day to day.
At all locations?
All locations.
There's what, 12? 12?
Well, there's 7 in Hampton Roads.
Right.
There's 12 in Virginia and North
Yeah.
Carolina.
Just, I know you guys have done this in Hampton Roads, but we have one in Northern Virginia, we have one in Charlottesville, Harrisonburg, South Boston, and then, Northeast North Carolina. Those ones
Yeah.
in the city.
And they're all seeing similar trends. So even like if some aren't like as at capacity as the others, it's just, we're all seeing the same trends. But I feel like there's got a lot of stuff here. Any other final questions for those who could stay? The rest got called back already.
I guess just one final thought from me.
Hold on. Switch.
Oh.
Yeah.
Sorry. Just sitting here listening to everyone speak, I think you guys asked some great questions. I'm really, really happy we got to talk about a lot of this stuff. We talked a lot about resiliency and how do we keep our morale up, and absolutely nurses, RTs, they are all struggling right now. I would say that applies to everybody in the hospital. So, we've got our nurse care partners, our ESD folks, our environmental services, our facilities folks, pharmacy, physical therapists, our food services folks. When we talk about taking care of patients at the hospital, it's not just the nurses, it's not just RTs, it's everybody. Everybody plays a key role in that team, and they're all feeling it right now. They're all struggling. And you're right, the resiliency is hard. All of those people recognize that there are ways that traditionally we have been able to take care of patients, and for lots of reasons now we can't do it the way we used to. And we feel like because of that, we're not providing the care that we in our minds want to provide. It's that idea of moral distress. We know what we need to do, we just can't do it because of things that are outside of our control. That is very, very difficult as a healthcare provider to get past and to feel like you're doing a good thing for our community. And ultimately, that's what all of us in the hospital, every single one, I'm sure I forgot some very important folks that are part of the care team, but all of us, at the end of the day, we want to be there for the community. When the community comes to the hospital, it's our job, it's our responsibility to be there when they need to be, and we want to be there. We're trying our absolute darndest to be there. It's just there are lots of things happening inside and outside the hospital that are making it hard for us to do that. And that's probably been the hardest thing from a resiliency standpoint.
Earlier, you had talked about two large populations right now in the hospital that are driving up capacity.
Mm-hmm.
And one of them being the deferred care
Mm-hmm.
group of folks. I'm wondering how much of those deferred care folks are the ones who had their elective procedures or non-urgent procedures on hold during that previous executive order, and now you guys are sort of playing catch up on them. Are they part of that lump that you're
Yeah,
talking about?
I don't know that I could give you are they 10%, are they 50%? I don't know the answer to that. It's definitely there. And I don't know that was, I don't disagree with that decision at the time. That's what made sense. But above and beyond just the surgery, delaying surgery, there are folks that during 2020, for whatever reason, whether it was, worry about, catching COVID, not being able to get into their physician office, for lots of different reasons, weren't able to get or didn't seek out care the way they would have before COVID. And that's what has really led to a lot of those diseases that were previously managed well enough to stay out of the hospital. Now they're not, and they need to be in the hospital to get them back under control. And then we have to have, and this is another area where there's, barriers, but once they're out of the hospital, having that infrastructure to keep that disease in control. And it's just not as easy or as available as it was before COVID hit, for lots of different reasons. And not because someone's not trying, but just there are new things that you have to account for, and it's a new world.
I'm gonna ask one question about capacity.
Sure.
You guys, do you know of any situation where you've diverted patients to other hospitals?
No.
Because you're just at capacity, or
As far as I know, we have not diverted any patients. Certainly at OBC, we've not gone on ambulance diversion. I don't remember who asked it, but there was a question about, at least what I thought the question was about how do the different hospitals work together to get patients the care they need, and that absolutely is happening. So shout out to Clarissa's team at OBC the other day. We had a patient who needed to go to ICU. We had no ICU. We were at capacity for ICU. Clarissa's team had an ICU bed, and so we transferred that patient to Virginia Beach. Those discussions are happening every single day, not just with ICU patients, but with all types of care. And so if somebody comes to Virginia Beach and they need a service that only Norfolk can provide, we're figuring out how to get them to Norfolk. And it doesn't happen as quickly as we would like, but we are figuring out how to get them to the hospitals where they need to be.
Can you speak to, speaking of leveraging assets and stuff like that? I talked to a patient, who was treated for COVID and released, and he was under the home health care program that we have. Can you speak to that a little bit more? For patients who are well enough to be discharged, but still need that extra care with that program, or with patients perhaps where they're not at a severe level to where they necessarily can be admitted, especially with the capacity issues that you have, but still need some monitoring and taken care of.
Yeah, that's a little bit outside of my area because, again, I'm more inside the hospital. I just like the hospital and like every other, field of healthcare right now across the country, home health is another area where there's more demand than they have people to work. And so that is something that we try to, it is a little bit of a juggling act, so to speak, coordinating someone who was in the hospital that's now ready to go home but needs home health and making sure that's available to them. Again, they're struggling just like the folks in the hospital are struggling to meet the demand for their services.
I've worked on that, and I can explain that without necessarily being on camera, but we have a Sentara to Home program where we partner our home health division with hospitalist physicians who work in the hospitals and manage all those patients. Hospitalist is like a whole specialty of medicine, hospital medicine, where the community physician hands off to the hospitalist who manages those patients. So under Sentara to Home, there's a daily visit from a nurse, a home care nurse, to those patients who are sick with COVID but well enough to isolate at home and be managed. And then while the nurse is present, they get a daily virtual visit from a hospitalist who is assigned to that patient. And between those two consultations, they can figure out how to best manage that patient at home, adjust medications, add oxygen, whatever they need. And then that's a way to keep people out of hospital beds who are sick enough to need care and isolation, but well enough to survive at home. So it's a partnership between home health and the hospitalist doctors so it can be somebody who gets sent home from the ED rather than be admitted, or it can be somebody who gets discharged and then winds up back at home with daily care. Because sometimes home care is like twice a week, that kind of thing, when you've been discharged in the hospital and they're doing wound care and stuff like that. This is much more intensive and it's daily in person.
I do want to add on, you all were asking about transfers, and we're a large system, we're the largest system in Virginia, so there's benefits to us having multiple hospitals that we can work together. But I did also want to make the point to say that all of the hospitals and health systems are working together. They're in close communication, they're in close collaboration, because we're all in this together. So Kelly, you could probably speak a little bit
Dale knows, sometimes you just can't stop me from talking.